Hello everyone, and on behalf of the LitFest Board of Trustees, welcome to this 42nd Lancaster Literature Festival. As many of you know, after a successful opening weekend, LitFest 2020 had to be cancelled due to COVID-19. So for this year's festival, our volunteer board realised it had to work in a different way and decided to create a diverse and inclusive festival to be delivered entirely free and entirely online. With support from Lancaster City Council, an Arts Council England project grant, our sponsors and partners, our aim, as we near the end of this long winter lockdown, has been to bring ashore a rich cargo of fiction, poetry, illustration and ideas, plus all kinds of activities and challenges. In fact, just like the ship of books cresting its stormy waves on the front of our programme. And as a registered charity with no regular Arts Council funding, if we are to be able to go on creating the exciting projects and events we want to, bringing the best in world literature and ideas to Lancaster and the Northwest and to our international audiences too, we're going to need your help. During the event, a donate button will appear on your screen, and every gift will help us to build towards the future where we can all actually meet again. But for now, at LitFest 2021, though physically distanced, we are, I'm glad to say, socially together. One of the four big projects we have created for LitFest 2021 is how we live next. That is, after COVID, after Brexit, and in the face of the climate crisis. A series of 5 events running throughout this weekend. Sir Michael Marmot, Fatima Ibrahim, James Sussman and Johnny Pitts will speak about health, environment, work and social justice. And the series will culminate in a panel discussion tomorrow afternoon with a more regional focus. Moderated by the philosopher A.C. Grayling, the panel includes Robert Barrett of Eden North, Mark Cropper of the papermakers James Cropper near Kendal, Lancaster City Councillor Gina Dowding, and Lancashire's Director of Public Health and Wellbeing, Dr. Sakthi Karunanithy. And in the last 15 minutes of each of these 5 events, there will be an opportunity to ask questions. Some have been sent in already, and you'll see in the bottom of your screen towards the right, the chance to ask a question, and I'll be picking up those once Michael has delivered his talk and we've had a conversation. So now let me introduce this morning's speaker. Sir Michael Marmot is Professor of Epidemiology and Public Health at University College London. He chaired the World Health Organization Commission on the Social Determinants of Health in 2005-08, the recommendations of which have been adopted by the World Health Assembly and taken up by many countries. The recommendations of his influential British government report on health inequalities, the Marmot Review, which came out in 2010, was just last year revised as Health Equity in England, the Marmot Review 10 years on. And those recommendations are now being implemented in 3/4 of local authorities in England. His books include The Health Gap, The Challenge of an Unequal World, and Status Syndrome. And I hope he'll talk to us about the study on which status syndrome was based when we get to the questions. So, without more ado, please give a warm digital welcome to Sir Michael Marmot.
Thank you, Bill, and it is a pleasure to do this. The opening line of my book, The Health Gap, was why treat people and send them back to the conditions that made them sick? When we think about health, particularly at the time of a pandemic, we tend to think about the healthcare system. Vitally important. Stay home, save the NHS. I want to talk about the conditions that make people sick in the first place. And the 2 books that Bill mentioned, in the Health Gap, which was the summary of a huge amount of research that I'd done, firstly for the World Health Organization, Commission on Social Determinants of Health, for my English review, the Marmot Review, Fair Society, Healthy Lives, and my own research at UCL. What we described was that in Glasgow, for example, for men, people in the most deprived area of Glasgow had life expectancy 54. In the most affluent part of Glasgow, life expectancy 82. A 28-year gap within Glasgow. Life expectancy for men in the poorest part of Glasgow was 8 years shorter than the average in India. Dramatic. The second observation, and this is what status syndrome was all about, is that health inequalities are not confined to poor health for the poor, but it's a social gradient. If you classify people by degree of deprivation, the more deprived of where they live, the more deprived the area, the shorter the life expectancy. And it runs all the way from top to bottom. And the point of the health gap was to lay out our understanding of how that comes about, starting from the beginning of life with pregnancy and childbirth, good early child development, education through the life course, and building on that. In my 2010 review, I had 6 domains of recommendations of what we could do to reduce health inequalities, and the evidence is laid out in the health gap. First, early childhood. Second, education and lifelong learning. Third, employment and working conditions. Fourth, having enough money to live on, having at least the minimum income necessary for a healthy life. Fifth, healthy and sustainable places in which to live and work. And sixth, taking what I call a social determinants approach to prevention. So smoking, poor diet are causes of ill health. But what are the causes of the causes? The determinants of why you're more likely to smoke if you're lower in the social hierarchy, more likely to have a poor diet if you're lower in the social hierarchy, the causes of the causes. My 2010 review, the Marmot Review, was urging government to do something about this issue. I was commissioned by a Labour government. They were voted out of office soon after. I don't think because of my review, I think it was separate. And the Conservative-led coalition government issued a public health white paper. And they said, this is the government's response to Michael Marmot's review. It is a key aim of this government to reduce health inequalities. We realize we won't do it through the healthcare system alone. And we need action on the wider determinants of health. I thought this cross-party stuff is easy. Commissioned by a Labour government, embraced by a Conservative-led coalition government. This is great, exactly what I wanted, to speak to people regardless of their political orientation. In the event, what the national government did over the period from 2010 on was not to follow my recommendations. And so in February 2020, I published a report, Health Equity in England, the Marmot Review, 10 years on. And my simple summary was, we have lost a decade, and it shows. I would never make a statement like that unless I had evidence. So what did we find? First, let's look at life expectancy. For about 100 years, life expectancy had been increasing about 1 year every 4 years. Wow, that's amazing. Every 4 years, another year added to life expectancy. If you spend 6 hours at the Lit Fest today, your life expectancy will be as long at the end as it was at the beginning. In fact, it could even be longer because of the nourishment and enrichment you got from the Lit Fest. And then in 2010, 11, that trend that had gone on for a century more or less ground to a halt. Life expectancy stopped improving. At the time, the government said, surely you couldn't be suggesting there was anything we did that could be responsible for this, could you? Maybe we've just reached peak life expectancy. Well, we looked at what had gone on in other countries, and what we found was that the slowdown in improvement in life expectancy was more marked in the UK than in any other rich country except Iceland and the United States. So no, we had not reached peak life expectancy. This was a slowdown that actually marked out the UK and the US as being different from other rich countries. Something was going on in our two countries that was not good. And my general assumption is that the health of society tells us something fundamental about how well that society is functioning. If health's not improving, society is not improving. The second health feature to which I drew attention in my Marmot review 10 years on was that the social gradient, which I've described, the more deprived the area, the shorter the life expectancy, the social gradient got steeper. Inequalities got bigger. And when we look at region, what we found was that for people in the least deprived 10%, it doesn't much matter where in the country you live. If you're rich, you can live anywhere and you've got relatively good life expectancy. The more deprived you are, the more it matters that you live in the northeast or the northwest compared with London or the south. The greater the disadvantage of being in the northeast or the northwest. And so when we look at what happened over the decade from 2010, for the poorest 10%, life expectancy went up in London, but went down virtually everywhere else outside London. So the picture in February 2020, before the pandemic crashed upon us, was slowdown in improvement in life expectancy, increase in inequalities by deprivation and region, and health for the poorest people outside London getting worse. What could have accounted for this? Well, the government that came in 2010 said, what we stand for is austerity, rolling back of the state. And they did it. In 2010, of gross domestic product, 42% went in public expenditure. And that 42% went down year on year. So by 2019, the 42% had become 35%. We were in the middle of the range of European countries in taxing and public expenditure in 2010, and we were at the bottom of the range by the end of the decade. And that reduction in public spending was done in a most regressive way. I'm going to give you some more numbers. If you look at local authorities in the least deprived 20%, the spending per person went down by 16%. And then the more deprived the area, the greater the reduction in spending. So in the most deprived 20%, the spending went down by 32%. In my 2010 review, I coined the rather awkward phrase, proportionate universalism, saying what we wanted were universalist policies, but with effort proportionate to need. What we got in spending by local government was effort inversely proportionate to need. The greater the deprivation, the greater the need. The greater the need, the greater the reduction in spending. Could this have played a role in worsening health and increase in inequalities? Yeah, of course it could. What do you think that money was being spent on in local government? If you assumed it's all being wasted because everything done in the public sector is waste of money, then you can cut and not have to worry. But on the assumption that it wasn't all being wasted, it was doing good things, if you make those kind of cuts, it's hardly a surprise if things get worse. And things did get worse. 1,000 Sure Start children's centres closed. Adolescent services for adolescents closed. The spending on adult social care went down. Things really did get worse, quite apart from threats to libraries and green space and amenities. And child poverty went up. After housing costs, 27% of children were in poverty. Poverty is defined as less than 60% median income. It's a relative measure. And child poverty went up from 27% to 30%. Not only were these regressive cuts to public spending in local government, the Chancellor paid attention to the tax and benefit system and made changes such that if you were a household of working age with children in the poorest 10% of household income, as a result of the changes the Chancellor made to tax and benefits, for the poorest 10%, your income would go down by 20%. And then for the next 10%, the next decile, it went down about 12%. And then the richer you were, the less the reduction. I showed a version of those figures to a former minister in the government and said, your government's policy was to make poor people poorer. He looked a bit uncomfortable and said, well, maybe it wasn't our explicit policy. Well, very clever people in Her Majesty's Treasury, they must have told the Chancellor this was the effect of his policies, and he did it. So that's where we were. Not a good situation in February 2020. Then came the pandemic. And the pandemic exposed and amplified the underlying inequalities in society. We saw a social gradient in mortality from COVID-19 that looked very similar to the social gradient in mortality from all causes, and high mortality in people classified as Black African, Black Caribbean, Bangladeshi, Pakistani, and to a lesser extent, Indian. Much of that excess in different ethnic groups could be linked to geography, where people live, which is related to deprivation, and to other socioeconomic characteristics. And of course, the poor got poorer. If you were low income, you were either in a sector that got shuttered, closed down, and if you were lucky enough to be covered by the furlough scheme, you got 80% of your salary. Now, if your salary was close to the poverty line and you're now getting 80%, you're below the poverty line. Or you had to go out to work in a frontline occupation and be exposed. And that's why when I did my second report last year, I called it Build Back Fairer. We do not want to go back to the status quo of where we were in February 2020. It was far from ideal. Health had stopped improving. Inequalities were increasing. Health for the poorest people was getting worse. Society was not in a good shape. Build back fairer. What did that mean? I had two kinds of recommendations. The first was put equity fairness of health and well-being at the heart of all government policy. And the second was follow my specific recommendations, which were in the domains that I mentioned at the beginning of my talk: early childhood, education, employment and working conditions, having enough money to live on, healthy and sustainable communities, and addressing the social conditions that give rise to healthy lifestyle or unhealthy lifestyle. One more thing to say before I stop. As you'll be aware, our handling of the pandemic was disastrous. If you look at excess mortality, in other words, not just from COVID-19, but from all causes, in the first half of 2020 compared with the previous 5 years, we had the highest excess mortality of any country. If you look at the US, most people are agreed that the US handling of the pandemic was a disaster. We were worse. So then I asked myself, what's the link between the fact that we were among the worst, along with the US, countries in terms of health improvement in the decade from 2010, and had the worst handling of the pandemic? What's the link between those two? And I think that link could work at 4 ways. First, the quality of governance and political culture. Second, the growth of economic and social inequalities. Third, the disinvestment in public services. And fourth, that we weren't very healthy coming into the pandemic. And I think to build back fairer, we have to address all 4 of those: the quality of governance and political culture, the growth of social and economic inequalities, the disinvestment from public services, and the fact that we're not very healthy. That's my recipe to build back fairer. Thank you, Bill.
So thank you, Michael. That was, as I expected it would be, an illuminating and incisive talk. And we're now going to just talk between ourselves for about 1/4 of an hour, and then we'll open up the discussion to the Q&A. So I want to go back to beginnings. And you mentioned this very phrase in your remarks. At the very beginning of your book, The Health Gap, you say, why treat people and send them back to the conditions that made them sick? And then you go on to say a little bit later that medicine is failed prevention. So I'm going to ask you 2 questions. One is, how could you put prevention into practice so that medicine was less necessary? And can you tell us a little bit about the beginnings of your work as an epidemiologist? Because you started in a slightly different field, I think.
Yeah, so I think about prevention in 2 kinds of ways. One is what a doctor or nurse does with a patient. You really shouldn't smoke, and you should make sure you come in to get your blood pressure checked, and try not to eat too much. We often think of that as prevention. Or come in for screening, breast cancer screening, cervical cancer screening, prostate cancer, and the like. The other way I think about it, which is what I write about, what I've just been talking about, is how do we deal with the social determinants of health? That's also prevention. How do we deal with the social conditions that lead to illness in the first place? And that's a very different approach to prevention. That's not what a health practitioner does with a patient. And my thoughts about that, really, to come to your second question, how did I get there, really went back to when I was a medical student and a young doctor in Sydney, Australia, and thinking about the fact that the people who came into hospital clearly had problems in their lives. And we were not dealing with the problems in their lives. We were dealing with the result of the problems, which was their illness. And when I was in my second year as a jobs as a junior doctor, we're dealing with chronic obstructive pulmonary disease and asthma. And the same people kept coming back. We would fill them full of steroids or whatever treatment, and they happily improve. Great. That's why you do medicine, because you want to help people who are sick. But then they'd come back again, sick again. And I thought, there's got to be a better way than this. We ought to be thinking, what can we do to prevent it? And so I went off to Berkeley, California, and did a PhD in epidemiology, looking at how people's rates of illness vary dramatically depending on where they live and how they live. And I've been doing that ever since.
This brings us on to a study that you made, which is in many respects, one could say, is the basis of your work. And I'm going to ask you to talk about the social gradient in health. But you spent many years conducting what's called the Whitehall study. And it was from that came the idea and the evidence for the social gradient. And I wondered if you could just tell us what the study was and how you developed it and some of the surprises that came out of it.
If you think back, and I'm not making assumptions about the age of people listening to this conversation, but the popular conception of heart disease was that it was people who were under real pressure, people at the top, work stress, working too hard, under pressure, stop working so hard, you'll have a heart attack. That was the popular conception. And there was a study when I came from Berkeley back to London to work at the London School of Hygiene and Tropical Medicine. The Whitehall study had started, and it was a study of predicting illness based on smoking and blood pressure, cholesterol, typical heart disease risk factor study. And I looked at grade of employment, people's position in the hierarchy. Now you have to think that civil servants exclude the richest people in society. There are no bankers or hedge fund managers, and it excludes the poorest people in society. They're all employed. I mean, if you're a low status civil servant in London, you're not rich, and it would be hard to live, but you're not unemployed, you're not the poorest. And in this population that excluded the rich and excluded the very poor, what we found was grade of employment was a potent predictor of mortality, not just from heart disease, but from a whole range of causes. So in other words, it turned on its head the popular conception. If you are high status, you were more likely to get a heart attack. Not true. The lower the status, the more likely you were to get a heart attack and die from a whole range of other causes. It was a social gradient. And trying to explain that social gradient, I couldn't, based on weight, blood pressure, cholesterol. Smoking made a contribution, but much of it was unexplained. And so I launched the Whitehall 2 study to look at the social gradient. And in addition to the things I've just mentioned, what we found was looking at work, people who had less control in the workplace had higher risk of physical illness, including heart disease, and mental illness. That was the insight to why it was that people at the top who notionally had more stress didn't have more disease. They had more control. They may have had more pressure on them, but they had much more control over it. As one senior person said to me, if stress were an infectious disease, I'm a carrier. I pass stress on to other people. I don't get the stress. The people below me get the stress. So little control. And that changed my understanding. And so when I chaired the World Health Organization Commission on Social Determinants of Health, we put empowerment at the heart of what we were trying to achieve, giving people agency, control over their lives, and saying that agency, having control, empowerment, had three dimensions. If you're very poor and can't afford to feed your children, you can't be empowered. So there was a material dimension, a psychosocial one, feeling like you do have control over your life, and a political one, having voice, knowing that what you say and think matters. So the insights from the Whitehall study, we found that social gradient to be very widespread. It was true nationally in Britain, and it was true wherever we looked, all over the world. We found these social gradients. The lower you are, the higher the risk. And as I described, we find it for COVID-19 mortality, as we do for heart disease and diabetes and chronic obstructive pulmonary disease. So it's true of infectious diseases and so-called non-communicable diseases. And the idea of empowerment, of creating the conditions that allow people to have more control over their lives, seem to be key.
Thank you, Michael. That's a very full answer, and it gives us a much better insight into what lies behind your work. Now, I want to jump ahead now to your book, The Health Gap. One of the striking statistics that your publishers picked out for the cover of the paperback was this, that in Sierra Leone, 1 in 21 15-year-old women will die of a maternal-related cause. In Italy, the figure is 1 in 17,100. But in the USA, the country that spends more on healthcare than any other, it is 1 in 1,800. Why the difference?
Well, I talked to a lot of different people, and I was giving a lecture to the American Society of Gynecology and Obstetrics. And I said to them, if you tell me that you deliver the best obstetric care in the world, I have no reason to disbelieve you. But if we look at the lifetime risk of a maternal death, the US ranks 63rd in the world. 62 countries have a lower risk of maternal death than the US. So there you are. You claim to deliver the best obstetric care in the world, and you rank 63rd. Good heavens. And then I said to them, my guess is if I asked you to write on a piece of paper the characteristics of the women who die of a maternal-related cause, and I collected those pieces of paper, they'd all have variants of the same thing. The socially excluded, the poor, people of color, illegal immigrants. You would all recognize that social determinants play a key role. It's not just that you've got the so-called the best obstetric care. People aren't getting it because of their social position. And that insight ought to affect everything you do, because we know the good obstetric care should make pregnancy almost perfectly safe, almost indistinguishable from perfectly safe, good obstetric care. Most of the conditions we deal with, that's not the case. We can't say if you've got cancer treatment will make you completely normal. Your life expectancy will be completely normal. We can't say that. It's not true. We can improve things. That's why we have healthcare. But we can't say it'll make you completely safe. So if social conditions are playing a key role in an area of medicine where you can almost guarantee 100% success, it's playing a much bigger role in areas of medicine where you can't guarantee 100% success. And I think the social conditions are crucial, what I call the social determinants of health.
Thank you. Now I want to move on to an area which has sort of come into focus in the last year or so, particularly. And that is that for a long time, healthcare and social care were treated as separate areas, for decades, in fact. But are they not two sides of the same coin?
I would pick up a different issue, which with social care. Half the workers in social care, adult social care in Britain, do not earn a living wage. And a high proportion are in the gig economy. So a worker will turn up to work at a care home, and the next day they'll be sent to a different care home. And the day after that, they may have no work. Or if they're doing home visiting, the way they used to work, huge pressure on them. Working conditions are absolutely dreadful for care workers. And it's not so much there's two sides of the same coin. When we were out at 8 p.m. on Thursday evenings clapping for NHS workers, rightly so, I did too, we should have also been clapping for care workers. And part of building back fairer should be to think about the nature of work in the kind of society we want. And workers in adult social care, to me, illustrate the problem. They perform an absolutely vital social role. You're a worker in adult social care and you go out to some dwelling where an older person, socially isolated, has soiled themselves. You have to change their nappy, as well as deal with the dressings on their ulcers on their leg. And in the past, you would have made them a cup of tea and sat and had a chat. Now your supervisor says, come on, get moving. No time for cups of tea and chats. You've got to get to the next one. These are appalling conditions. Now, that's going on in the NHS too, but not quite to that extreme. So I think part of building back fairer is actually thinking about who plays these key roles in our society. We need proper job structures for care workers and for all the other essential workers. They need training, they need job security, a proper job structure. So yes, health and social care are closely linked, of course. But I think in both cases, we need to think about the nature of the work that they do.
Just thank you for that. And just to follow on from there, Michael, do you think that those spheres of work could be usefully integrated, or is it in some way helpful that they should be separated?
I mean, the machinery of government questions and how you organize services, I don't have any special insight. It seems to me to make sense that there should be integration, and the 2012 Health and Social Care Act said integration, forget it. What we want is competition. We don't want integration. The more disintegration, the better. We want people competing. Now, the new white paper has reversed that completely and said, no, we want integrated care services. We're at the mercy of the whims of political leaders who say more integration, less integration. I mean, in principle, it seems like a good idea to have health and social care more integrated. I mean, we saw what happened during the pandemic. In the early phases, older people were decanted out of hospitals into care homes where they contracted COVID-19, spread COVID-19, and died. That wasn't a great solution to anything. So some better coordination would be helpful.
Thank you. Now, my last question I'm not going to ask because it's cropping up in some of the questions that we have been submitted or were submitted in advance. But just before we move to the Q&A, I'd just like to say, if you would like to support LitFest's work, please click on the donate button, which should be appearing on your screen any minute now. And you can be sure that every penny will go towards creating exciting future projects and events like the one we're witnessing now. So here is the first of the questions. Some of them these first two were asked before you gave your talk, Michael, so there may be some elements that you've covered already. In the light, says Sue Thompson, of the spread of COVID-19 and the UK's response to it, how would you advise the government to prepare now for the next pandemic?
Well, I think I would answer it at two levels. One is the technical level. It's Sir David King, who was a former government chief scientist, said that he thought back to flood defences, and that the government in 2010 stopped spending money on flood defences. It's a waste of money, we're trying to cut everything. We want a smaller state, so why waste money on flood defences? So they scrapped it. Then we had huge floods, and the Prime Minister said, money is no object, we'll spend whatever it needs. Well, they just finished scrapping spending on flood defences. Then they had floods, and then they said, oh no, we'll spend whatever it takes. So it was partly the feeling that, oh, we don't need to be prepared, that's a waste of money. And likewise, we were not prepared for the pandemic. And we need to be prepared. We know that now. Well, we knew that before. People were predicting there'd be a pandemic, whether it was going to be SARS or Ebola or Middle East respiratory syndrome. We knew something was coming. We just didn't know when and what form it would take. Nobody predicted it would be as dramatic as this. But we needed to be prepared. So that's kind of a technical level. But then it comes back to my quality of governance and political culture. If you forget which party you belong to, if you were looking at Britain from the time of the Brexit referendum to the 2019 election, that 3-year period, and you're looking from the outside, and you said, what are the issues that exercise the British public? It was all Brexit. And it wasn't even a substantive discussion about Brexit. Northern Ireland, what was going to happen with Northern Ireland? Oh, said the Prime Minister breezily, trust me, it'll all be fine. And then, of course, it turns out it wasn't fine. Okay, well, we'll scrap the rules. We know we signed up to an agreement. We'll break the agreement because it's a bit inconvenient with Northern. We were not having a discussion about how to create a better society. And health was getting worse. I mean, what I reported in 2020, we'd noted that along the way. Health was getting worse. Child poverty was going up. There were all sorts of problems going up. And we weren't talking about them. We're talking about this Brexit nonsense. Absolute, complete, utter nonsense. And with more disinformation, lies, than you could shake a stick at. It was just ridiculous. So it's not just the quality of governance, it's what I mean by the political culture. We were not engaged in real public debates. And there's very important public debates to be had. If you're to the right of the political spectrum, you say, I'm all for individual responsibility. And if you're to the left, you say it's social responsibility. Well, that's a very important discussion to be having. Where does the individual and the social where's the appropriate dividing line? And these are very important discussions. And whatever my view about where that dividing line should be, I respect people who have a different point of view, provided they're arguing from good faith, provided they're not lying and carrying on about God knows what. That's got nothing to do with that important discussion. So the quality of governance was dreadful, absolutely dreadful, and the political culture. So to come back to the question of what have we learned? What we've learned is listen to the scientists about what we need to do to prepare for the next pandemic. But secondly, the quality of governance and political culture really matters. And it's been dreadful in this country for the last few years.
Thank you. Now, the next question is from Emily Todd, and it is, thank you for all your brilliant work. Have you ever felt paralyzed by short-term political cycles? And if so, have you felt tempted to enter the political world? If not, what has stopped you?
Let me tell you a story. A few years ago, I was invited by the government of Argentina they were holding a conference on primary health care and whatever, and I was invited to talk about social determinants of health. And then after the first day of the conference, they had a dinner for the speakers. And as is my wont, I went over, sat in a corner, as far away from the main table as I could get. And a civil servant went and collared me and said, no, you've got to come and sit at the main table. So I went and sat at the main table. And there was the Minister of Health of Canada and the Minister of Health of Mozambique. The host was the Minister of Health of Argentina, the Director General of the World Health Organization, the Regional Director for the Americas, and 3 other ministers of health, Mexico. And I looked and thought, every one of these people has a hinterland, has a huge bureaucracy. They can go back home and they can order the bureaucracy around to do what they do. And all I have is my ideas. And I thought, I wouldn't change places for anything. I can speak truth to power. If they don't want to listen, they don't listen. So what? I mean, I tell the truth. I was asked by a senior politician recently, we don't seem to be taking the public with us. Can you advise us what we should be doing? And I said, not much has come with age and experience, but one thing that I've learned is what I'm good at and what I'm not good at. And what I'm not good at is telling politicians how they should take the public with them. I can tell you what I do, which is tell the truth, show the evidence, and invite people to engage in the conversation of what kind of society we want. So to come back to the first part of that question, it's not only national government that we're talking to. After my 2010 report, Coventry said, we're a Marmot city. We're going to take your review and going to use it as the basis for building a better Coventry. And then Greater Manchester took it on. And they talk about implementing Marmot in Greater Manchester. We've been working with Gateshead. We've been talking with local government around Britain. I was invited to Italy, to Trieste. They said Trieste is an Italian Marmot city. And then I was invited to Bologna, Marmot city. I was getting the wind of this. And I said, when I went to Bologna, I said, are you a Marmot city or did you just say that to get me here? No, we just said that to get you here. So no, of course they're not a Marmot city. But that didn't matter. What they're doing is trying to improve the conditions in which people are born, grow, live, work, and age, the social determinants of health. So I can't remember if Italy has a national government at the moment. Most people in Italy never quite know what the national government's doing because it keeps changing, and I think they've got one. I think Draghi's the head of it at the moment. But what's happening in the cities in Italy is really exciting and really important. They vary enormously. So it's not just the cycles, and Italy's a case in point. Nobody in Italy, I'm exaggerating now, nobody in Italy cares what happens at the national government level. It doesn't affect their lives very much. They really care what happens in their city and locality, in their province and commune and the like. That really matters. And that's where the action is. And some cities are really taking this on and doing it, as we're finding in England. So, no, I don't get frustrated. Well, I do get frustrated at the national government. But what gets me excited is voluntary organizations, city government, NHS people who say, yep, we've listened, we want to do it.
Thank you. But notwithstanding that answer, our next question from Jenny Walmsley says, if you were in government and could do just one thing to build back fairer, what would it be?
Well, I've always resisted the what's the one thing question, because if I only had one thing to do, I'd only make one recommendation. And I'm not going to say that the Department of Environment should cease to exist because I want you to invest in early child development, or the Department for Education would cease to exist because I'd like business to work in a different way. So I want lots of things to happen, but I want a cross-government strategy with equity of health and well-being at the heart of all government policy. And it's got to be a cross-government strategy. So that's the one thing. Make this not recovery of GDP, but building back fairer, putting equity of health and well-being at the heart of all government policy. That should be the number one thing.
Okay, now the last question we have time for, because you've answered some of the questions that you can't see actually, Michael, but I can see on the question sort of line. So the last one is, we know, and this comes from Tim Mansfield, we know the horrendous excess death toll in the UK, but can we also expect a secondary shock from the lack of control and agency we have had over our lives because of lockdown and the associated restrictions on our lives?
Oh, very much so, very much so. And it illustrates what I said in relation to my chairing of the WHO Commission on Social Determinants of Health, that if you haven't got the money to feed your children, you can't have agency. And it took a footballer to draw the nation's attention to the fact that people couldn't feed their children. So that's lack of agency. Those scenes that last week of people queuing up round the block and round the block again to attend a food bank, that's lack of agency. But then not having a job, not being able to control the circumstances of your lives. And it's really the topic for another talk, so I try not to get into it. But let me just say that the illusion of agency is really damaging. So the idea, and comes back to what I said briefly about personal responsibility, the idea that's promoted that you are responsible for your own life. It's your fault if your kids are suffering. It's your fault if you don't know how to cook a healthy meal for your children. You've got no one to blame but yourself. And that's the illusion of agency. If people are too poor to buy healthy food, If people are in a job, they're employed, but they're still below the poverty line, it's not their fault. It's the fact that they're lowly paid is the problem. So the illusion of agency is really troubling. The idea that we're all responsible for our own lives, but then you're not in a position because of your social conditions. So to come back to the question, lockdown exaggerated that. If you were out of a job, what are you supposed to do? How do you get out of that? The job that you were doing, that's imposed lack of agency. And the illusion of agency makes it worse.
Thank you, Michael. And thank you for your really stimulating and illuminating talk, and then for answering some very good questions in real detail. It's got us off to a flying start and set out clearly some of the things that need to be done if we're to build back fairer. You can buy Michael's fascinating and passionately argued book, The Health Gap, from our online bookshop, and every purchase from the LitFest bookshop helps us to fund future events and projects. We hope you'll be able to join us for more talks in this series, starting later this afternoon with Fatima Ibrahim of Green New Deal UK and her talk on the environment. But before we go our separate ways, if you enjoyed today's event, don't forget to click on the donate button on your screen or on our website. Every penny will go towards creating exciting future projects and events and strengthening LitFest as an independent arts charity. So thank you for joining us today. Thanks again to Sir Michael Marmot for that terrific talk and answering the questions, and see you all soon. Bye now.